Presentation is on the physical examination of urine, Chapter 4 of the reference book, Urinalysis and Body Fluids, 6th edition, by Susan King, Strasinger, and Marjorie Schwab de Lorenzo. There is now a 7th edition out, and this chapter is now Chapter 5 in that edition. The audience for this presentation is students in a medical laboratory technician or medical laboratory scientist program. This presentation includes a lecture, definition of terms, and some questions. My name is Jean Riddell, and I hope you find this presentation useful in your studies. The objectives for this presentation include being able to list the common terminology used to report normal urine color, discuss the relationship of urochrome to normal urine color, state how the presence of bilirubin, biliviridin, erythrin, and urobilin in the specimen may be suspected, discuss the significance of cloudy red urine and clear red urine, name 2 pathologic causes of black or brown urine, discuss the significance of pyridium in a specimen, state the clinical significance of urine clarity, list the common terminology used to report clarity, describe the appearance and discuss the significance of amorphous phosphates and amorphous urates in freshly voided urine. Objectives continued should be able to list 3 pathologic and 4 non-pathologic causes of cloudy urine, define specific gravity and tell why this measurement can be significant in the routine analysis, describe the principles of the refractometer, reagent strip, and osmolality for determining specific gravity. Given the concentration of glucose and protein in a specimen, calculate the correction needed to compensate for high molecular weight substances in the refractometer specific gravity reading. Describe the advantages of measuring specific gravity using a reagent strip and osmolality. State possible causes of abnormal urine color. This slide lists key terms that you should understand the meaning of as a laboratory technician or scientist. These terms are clarity, hyperstheniuric, hypostheniuric, isostheniuric, and refractometry. Additional key terms: specific gravity, urobilin, urochrome, uroerythrin. The physical examination of urine includes the determination of the urine color, clarity, and specific gravity. I have added odor since this may not be something that is measured, but you will notice the odor of a urine when it is particularly bad. When you observe these characteristics of a patient's urine, you have some preliminary information on bleeding within the glomerulus, liver disease, inborn errors of metabolism, or urinary tract infections. The specific gravity helps to evaluate the ability of the renal tubules to concentrate urine. Urine is normally some shade of yellow due to the pigment urochrome. The color can be affected by normal metabolic function, physical activity, ingested materials, and pathologic conditions. The yellow color of urine is caused by the presence of a pigment called urochrome. 2 other pigments that have less effect on the color are urobilin and uroerythrin. A normal urine can be clear to dark yellow. A clear urine is usually caused by recent fluid consumption and is seen in random urines. A pale yellow urine can be a normal dilute sample due to fluid consumption. It can also be polyuria and diabetes insipidus with an increased volume and low specific gravity. You can also see a pale yellow in diabetes mellitus. This would have an elevated specific gravity and a positive glucose test. A dark yellow is seen in concentrated specimens after strenuous exercise or the first morning specimen. B vitamins can cause the urine to be dark yellow. Dehydration due to a fever or burns will darken the urine. Bilirubin can also cause a dark urine and will foam when shaken. A striking orange-yellow can be caused by medication pyridium used for a UTI, and it can interfere with the dipstick test. This slide covers the abnormal urine colors. Yellow-green can be caused by bilirubin oxidized to biliverdin. This would have colored foam in acidic urine, and the dipstick would be false negative for bilirubin because it does not detect biliverdin. An infection with Pseudomonas can turn the urine green, and the urine culture will be positive. A blue-green color is normally caused by medications such as methylblue and methylcarbamol, and the patient will have a diagnosed condition with a prescription for these medications. Pink is caused by red blood cells, and this will have a positive dipstick and red blood cells seen under the microscope. Red is hemoglobin or myoglobin, beets, or menstrual contamination. There will be a positive dipstick for the myoglobin, hemoglobin, or blood, and positive microscopic with menstrual blood. Brown is caused by homogentisic acid, alpha-captonuria, and the urine will be alkaline after standing. Black urine can be caused by malignant melanoma and several other causes. The urine darkens on standing and reacts with nitroprusside and ferric chloride. Red urine differentiation. If the urine is red, we can look at the clarity of the sample to help us differentiate the cause. If it is cloudy, then you would have hematuria, or red blood cells present in the urine. This would cause a positive dipstick and a positive microscopic test. If the clarity is clear, then you have either hemoglobinuria, which is free hemoglobin in the urine, or myoglobinuria, which is myoglobin in the urine. To differentiate these two, you can look at the patient's plasma. In hemoglobinuria, the plasma would be red, indicating hemolysis. In myoglobinuria, the plasma would be clear. The clarity of a urine sample can be clear, hazy, cloudy, turbid, or milky. Clear is normal. A random sample could be hazy due to epithelial cells. Cloudy, turbid, and milky are usually due to some sort of problem. Evaluate the clarity of a mixed sample at room temperature in the collection cup before pouring into the conical tube. A clear sample is transparent. A hazy urine has few particles and you can read through it. Cloudy is too many particulate and print is blurred through it. A turbid sample cannot be read through. A milky sample may precipitate or be clotted. When determining the color and clarity, you should have an adequate volume of sample. The sample should be well mixed and not settled. The container must be clear. The background should be white. You should have adequate lighting, and you should use a consistent volume from patient to patient. Causes of turbidity and significance. Turbidity in urine can have non-pathological and pathologic causes. Non-pathologic causes include squamous epithelial cells, mucus, amorphous crystals, semen, fecal contamination, radiographic contrast media, powder, and vaginal creams. A sample that is refrigerated can develop a thick turbidity caused by the precipitation of amorphous phosphates, carbonates, and urates. A sample that is improperly left out at room temperature can allow bacteria to multiply and give a false positive test for a UTI. Pathologic reasons for turbid samples include red blood cells, white blood cells, yeast, non-squamous epithelial cells, abnormal crystal, lymph fluid, and lipids. Specific gravity. One of the most important functions of the kidney is to reabsorb nutrients, reabsorb water, and secrete waste. The specific gravity helps us to evaluate these functions of the kidney. The specific gravity is affected by the number of particles and also the particle size. Large particles have a greater effect than smaller particles. Specific gravity. Terms used to describe specific gravity are isothenuric, which is a specific gravity of 1.010, because this is the same as the specific gravity of the plasma filtrate. Less than 1.010 is hypo, and greater than 1.010 is hyper. The normal range is 1.002 to 1.035. And if a sample is below 1.002, it is not likely urine. The usual range will be 1.015 to 1.030. Specific gravity methods. The refractometer can be used to measure the concentration of dissolved particles in a specimen by measuring refractive index. The advantage of this test is that you can use just one drop of urine. The disadvantage is that corrections are required if protein or glucose are present. To make corrections, subtract 0.003 for each gram of protein present and 0.004 for each gram of glucose present. If you don't get to use a refractometer in your lab, refer to Figure 4-3 in your book for instructions, or Figure 5-6 in the 7th edition. The most common method used in the laboratory for routine testing is the dipstick, which detects the pKa, change of polyelectrolytes by ions present. Polyelectrolyte ionizes, releasing hydrogen ions in proportion to the number of ions in the urine. When there are more hydrogen ions in the released, it causes the release of hydrogen ions in the reagent pad, decreasing the pH. The bromethyl blue indicator, which changes from blue to green to yellow as the specific gravity is higher. Osmolality is a better indicator of urine concentrating ability because sodium and chloride and urea affect it more equally, but it is a more complex testing method. So remember, we usually use the dipstick. Odor. While odor is not normally part of a urinalysis exam, it is a noticeable physical property. Normal urine has a faint aromatic smell, and older samples will smell like ammonia due to the breakdown of urea. Someone with a UTI, it can smell horrendous. That's a good way to describe it. While odor is not normally part of the urinalysis exam, it is a noticeable physical property. Normal urine has a faint aromatic smell, and older samples will smell like ammonia due to the breakdown of urea. If the odor is aromatic, this is normal. If it's foul ammonia-like, it's probably a bacterial infection. If it's fruity sweet, this can be due to ketones because of diabetes mellitus, starvation, or vomiting. Maple syrup, the person may have maple syrup urine disease. If it's mousy, it may be phenylketonuria. If it's rancid, it may be tyrosinemia. Sweaty feet, isovaleric anemia. If it smells like cabbage, this may be methionine malabsorption. If it smells like bleach, it means someone got some bleach in the sample cup, so that sample's no good. Definitions and terms. Clarity, the transparency of urine ranging from clear to turbid or milky. Hyperstheniuric, pertaining to urine-specific gravity greater than 1.010 of the glomerular filtrate. Hypothenuric, pertaining to urine-specific gravity lower than 1.010 of the glomerular filtrate. Isothenuric, pertaining to urine-specific gravity at the same as 1.010 of the glomerular filtrate. Refractometry, a measurement of light bending capability of a solution. Specific gravity, the density of a solution compared with that of a similar volume of distilled water, influenced by both the number and size of particles present. Urobilin, the oxidized form of urobilinogen that provides the brown color of feces. Urochrome, the yellow pigment produced by endogenous metabolism that imparts the yellow color to urine. Uroerythrin, pink pigment in urine derived from melanin metabolism that attaches to urates in the sediment. Questions. Question 1. The normal urine color is A, straw to dark yellow, B, orange, C, brown, D, black. The answer is A, straw to dark yellow. Question 2. What substance primarily gives urine its color? A, uroerythrin, B, urobilin, C, urochrome, D, methyl blue. The answer is C, urochrome. Question 3. What would make you suspect bilirubin is in the urine? A, fruity sweet, B, mousy smell, C, yellow-green color, D, turbid. The answer is C, yellow-green color. Question 4. What is the significance of red urine? A, maple syrup urine disease, B, blood, C, liver disease, D, phenylketonuria. The answer is B, blood in the urine. Question 5. Significance of the urine of a young child that is mousy smelling. A, odor is not significant. B, maple syrup urine disease. C, diabetes mellitus. D, phenylketonuria. The answer is D, phenylketonuria. Question 6. What might be the cause of a black urine? A, left out for a day. B, malignant melanoma. C, diabetes mellitus. D, phenylketonuria. The answer is B, malignant melanoma. Question 7. The urine is orange and the dipstick doesn't work. What is the cause? A, pyridium. B, methyl blue. C, diabetes mellitus. D, phenylketonuria. The answer is A, pyridium, used for UTIs. Question 8. What is the normal clarity? A, turbid. B, hazy. C, clear. D, cloudy. The answer is C, clear. Question 9. What would a sample with amorphous phosphates have? A, positive glucose. D, positive protein. C, clear appearance. D, cloudy appearance. The answer is D, it would be cloudy. Question 10. What is found in a non-pathological cloudy urine? A, squamous epithelial cells. B, bacteria. C, red and white blood cells. D, yeast. The answer is A, squamous epithelial cells. Question 11. A pale yellow urine with a high specific gravity and a positive glucose test would be found in a patient with what condition? A, diabetes insipidus. B, diabetes mellitus. C, oliguria. D, maple syrup urine disease. The answer is B, diabetes mellitus. The key is that high specific gravity and glucose together. And pale urine because it's more dilute. Question 12. What method of specific gravity needs corrected if there is a positive test for glucose or protein? A, dipstick. B, refractometer. C, osmolality. Or D, urinometer. The answer is B, refractometer. Question 13. What is the method of choice for routine urinalysis specific gravity testing? A, dipstick. B, refractometer. C, osmolality. Or D, urinometer. The answer is A, dipstick. Question 14. In a bacteria infection, what would you find? A, an ammonia-like odor. B, a clear sample. C, aromatic odor. D, low specific gravity. The answer is A, ammonia-like odor. CFADavis.com to find the book Urinalysis and Body Fluids by Susan King Strasinger and Marjorie Schwab Di Lorenzo. Thank you for listening, and I hope this helps with your studies.